Tara, you have to turn off your video, please. Once your name is announced, Dr. Goma, then you have to turn on your video, please.
Okay.
Yes, sir, you can start now.
1, 2, 3. Good evening, everyone. This is Abhijit from Cadila Team Zambia with my colleague, Mr. Nikhil Vankarekar. Today, we have a very great opportunity and very wonderful occasion that is called World Heart Day. That is the logo, the caption word of this year World Heart Day is Connect Heart with Heart. So Cadila Pharmaceutical welcome you all the participants on the live mega webinar that is World Heart Day. Let me introduce my senior, Mr. Mahidwa Sisodia, who is heading the international business across the globe behalf of Cadila. Let me introduce Mr. Sisodia and welcome, sir. Please address the group. Over to Mr. Sisodia.
Thank you, Abhijit. Nikhil. And welcome to all the participants here. Very good evening to all of you in Zambia and other places where you are joining from. It's indeed our pleasure to have all of you here on this occasion of the World Heart Day. First of all, I would like to thank you for your time today evening. I know your busy schedule, especially today. However, I'm sure we are going to have very interesting panel discussion later today with help of Dr. Goma, Dr. Bishara, and our own Dr. Vipin. Before that, I would like to take this opportunity to talk about Cadila Pharmaceuticals. Even though most of you would be very well aware about Cadila Pharmaceuticals, but it's my duty to update you about the organization and talk a little bit about the history of the organization. So when I talk about the history of the organization, it really gives me a lot of pride in sharing with you that we are one of the most established Indian pharmaceutical company from India in different parts of the world. And why do I say so? Because we started in 1951, just 4 years after the Indian independence in 1947. It was the vision of our founding chairman, Mr. I. M. Modi, who led the foundation of the organization. And not only he had a dream of making the affordable medicine available to the common person in India, but very soon after establishing the company, he has gone to different parts of the world and continue to take this journey forward. And one of the first place to start this was African continent. And therefore, we take a lot of pride in the fact that we have been in East African countries for decades now. And Zambia is also part of it. I know that today it's more about cardiology, but we have been known across various segments and various therapeutic segments. We have been offering to medical fraternity and pharmacies around the world. Today, we are present in more than 80 to 90 countries across all geographies. Our manufacturing plants are approved by almost all authorities of the world, starting from US FDA, UK MHRA, Europe, Australia, you name it, and we are there. We generally believe in being near to the place of action, and therefore we have our offices around the world. We also have our own teams in different parts of the world, and therefore you find our team very near to you in Zambia all the time. We have been present in Zambia through our partner, Yash Pharmaceuticals, and along with them, our endeavors always have been to make the quality medicine available at the affordable prices. And we know that we cannot be successful in this effort without the help, confidence, trust, and collaboration from your end. And we always value this relationship and would like to continue working with you to take this entire journey to next level. As you know, we are located in Ahmedabad, which is our headquarters. Also, we always continue to expand our presence in Africa. Therefore, we have a manufacturing plant also in Ethiopia. Today, I would like to take this opportunity to convey our commitment to especially the cardiology segment. We have a number of brands catering to various requirements from your end, and we continue to add more products going forward in this segment. So I'm sure today's opportunity would be also for you to know more about us, to know more about our efforts, and my team will also talk about it. Without saying more about the organization, I would like you to invite to have a look at our corporate film, which will give pictures to what I said just now. Can we have the corporate presentation film?
Behold, the story of victory, of life over malady. Behold the saga of power, of science over sickness. Behold the tale of triumph, of dedication over disease. Behold the rise and rise of Cadila Pharmaceuticals Limited, one of India's largest privately held pharmaceutical companies based out of Ahmedabad, Gujarat, India. Cadila Pharmaceuticals was born out of the vision of a legend who left an indelible mark in the chronicles of Indian pharmaceuticals industry. He was Indravadan Ambalal Modi, the founder chairman of the company, rightfully christened as the medicine man of India. For Shri Modi, healthcare was not a privilege of the few. It's the fundamental right of all.
In 1951, I know that when pharmaceutical industry was not existing in this country, and people felt that being a technology-oriented industry, perhaps it cannot be started in this one. And at that time, I decided that in the interest of the country and everything, better we may give a foundation so that other people also follow for this industry.
His vision to alleviate pain of the underprivileged through research-driven innovations has been driving Cadila Pharmaceuticals for more than 6 decades now. Innovations which are backed by the key strengths of the company, the state-of-the-art manufacturing and research facilities. The flagship manufacturing facility at Dholka, Gujarat, sprawls over 100 acres. This avant-garde facility is US FDA approved, besides meeting most of the stringent quality standards across the globe. It manufactures tablets, capsules, injectables, liquids, and orals. The second formulations manufacturing facility is located at Samba in the state of Jammu and Kashmir. The API facilities at Ankleshwar, Gujarat, manufacture a large number of key APIs and intermediates at this US FDA and ISO 9002 and ISO 14001 accredited plant. The company also has set up its first ever overseas formulation manufacturing facility at Addis Ababa in Ethiopia. This world-class facility is the only WHO CGMP compliant manufacturing facility in the region. Cadila Pharmaceuticals offers an ensemble of formulations. The company's extensive range of finished dosage formulations covers more than 850 products spread across 12 specialties with many of India's top brands in its basket. Great goals are defined by far-sighted vision and achieved by seamless teamwork. A multicultural, multilingual, and multinational workforce of over 7,000 employees is truly the propelling power of the company. The company is a significant player in domestic market with a field force of over 4,000 and covering over 250,000 doctors, including all specialists and generalists. Not just in the domestic market, The company has a wide global footprint with over 1,000 marketing authorizations across 85 countries. Its international sales force of over 150 highly diversified and versatile personnel lends it an outreach that blankets the globe. Evolution through innovation is Cadila Pharmaceuticals' credo. As the company grows, so does its commitment to research. Manned by more than 350 scientists, the R&D facilities of Cadila Pharmaceuticals at Dholka, Gujarat is an institution of breakthrough innovations, such as Polycap, the world's first polypill for cardiovascular diseases; Rizorin, the world's first boosted rifampicin for tuberculosis; Mycidac-C, the world's first active immunotherapy for lung cancer; and novel formulations like Rabiloc IV, the world's first rabeprazole in IV form. To take the focus on innovation to the next level, Cadila Pharmaceuticals believes in forging scientific collaborations with world-class institutions sharing the same passion for healthcare research. It partners with leading international companies to discover newer treatments in the areas of novel vaccines, better antibiotics, respiratory diseases, gastrointestinal diseases, cardiovascular ailments, diabetes, cancer, sepsis, and regenerative medicine. The Cadila Pharmaceuticals Group is gigantic. Its group companies complement and expand the dynamic vision of the company across new avenues of healthcare and newer fast-paced business areas. Cadila Pharmaceuticals is a gentle giant. It undertakes a number of targeted activities that are bringing about long-lasting and deep-rooted changes, especially in the fields of health, education, women empowerment, and child care. As a responsible corporate citizen, Cadila undertakes a number of CSR activities in these areas. When the beacon of exemplary leadership passed on from the illustrious Doyen Shri I.A. Modi to Dr. Rajiv Modi, Cadila Pharmaceuticals scripted a new success story in its journey of fast-paced growth phase.
For me, it's a mission, and I have a very simple mission, which is to take this company forward at all costs, to make it into a globally sized business, which will continue to provide the world's best quality, affordable medicines for people around the world, and would strive to bring innovations.
Strategic global expansions and research into areas of unmet medical needs are the future. Decades of dedicated research, groundbreaking healthcare innovations, and worldwide impact proves the infinite potential of one powerful emotion: care. Care that transforms into a driving force for a revolutionary change. Care that translates into affordable miracles for those who need it the most. The success of Cadila Pharmaceuticals bears testimony to the fact that the care continues.
So, thanking you once again for your valuable time today. And before I finish, I would like to convey best wishes on behalf of our Chairman Managing Director, Dr. Rajiv Modi, and look forward to many more associations going forward. Over to you, Abhijit.
Yes. Thank you, Mahendra sir, our international business head, HOD. Mahendra sir, thank you very much for giving your precious time and sharing your knowledge with us. Now I would like to hand over this session to Professor Faston Goma, the President of Zambia Society for Hypertension and Zambia Heart Stroke Foundation, and the Chairperson for the Zambia Non-Communicable Disease Alliance. Works experience as a Deputy Vice Chancellor, Eden University, Associate Professor for Physiology and Cardiovascular Research, University of Zambia, Dean, University of Zambia School of Medicine. Professor Goma has done 30 plus papers published on cardiovascular diseases and tobacco control and HIV. So I'd like to hand over the sessions to Professor Goma. Professor Goma, welcome you to this live webinar that is called World Heart Day, Connect Heart with Heart.
Thank you very much, Abhijit, and many thanks to Kadila for giving us opportunity to meet this evening, and hoping that we'll have a good time exchange. Is of utmost importance as we get to control cardiovascular disease, especially that, wave 3 of COVID-19 has just passed and we are still expecting wave 4. And one thing that was clear in that cardiometabolic diseases actually were the main menace. Most of our patients who we lost in the wave 3 were those who had cardiometabolic issues with them. And I'm glad that this evening we could give some prominence to hypertension among all the other diseases that I think we need to talk through. And really tonight, we would want to also take time to launch the Facebook page for the Zambian Society for Hypertension. Now, one thing I think that the Zambian Society for Hypertension is trying to do is to provide a platform where we can do a lot of information exchange. We are hoping that we can have a page that will be active and that will be open to a lot of you to throw in questions, to throw in suggestions and proposals. And I think our approach is more from the practice point of view rather than academia. And so we are hoping that those who have information on how best to curve our practice will take the utmost place in trying to communicate on this platform. So I think at the end of our talk, we will be launching a Facebook page for Zambian Society for Hypertension. And I think we are welcoming all of you to be members, and we will be posting out the application forms. You can sign in and join us. I'm going to give just a little talk about hypertension, really to lay ground for some science that we will discuss. At the beginning of COVID, the COVID pandemic, it was shown that hypertension was going to be one of those diseases that we are going to grapple with. And unfortunately, ACE inhibitors were the first culprits to go down, in that where the publications came out saying, well, the SARS-CoV-2 virus actually uses ACE receptors. And so if we use ACE inhibitors, they multiply ACE receptors and therefore cause more disease and more death. And so we had to try and look for more evidence to try and see what drugs can we use that are safe. But I think it all made us sit up and made us get to appreciate sources of information. We have continued looking after hypertension, but really hypertension has continued to be what we may term the silent killer. We are yet to analyze the data that we've got from the Levi Mwanawasa COVID Center, because we have a data set that comprises just about 200 patients from there. And we have contributed that data to the World Health Federation data set that has more than 5,000 patients with cardiovascular issues. And so we are just putting our heads together now to analyze, to try and see what COVID did actually to the hypertensive patients and how best we are going to attend to it in wave 4. And so for now, hypertension continues to be a silent killer. But really, I think as doctors, we ought to declare war on hypertension. We did it for HIV, and I think we brought down mortality and even morbidity. Most of our HIV patients now are living near normal life, so to say. I think you can do the same for hypertension. Let us bring this disease into total control. And so when we talk of 90-90-90 in HIV control, I think we must move towards 90-90-90 also for hypertension control. It's time that people knew their blood pressures, and 90% of those who are hypertensive must be put on medication, and 90% of those on medication must have their blood pressures controlled. In our 2019 data, it shows us that in Zambia, control of blood pressure is at 9%. That's lower than the African average of 15%. So I really think that, we need to do our best to put in place therapies that are going to be effective, but also treatment regimes that work and that are effective for our population. And it's good to see senior cardiologists gathered here this evening, and I'm sure they will be able to add voice to these things. But really, all we are saying is that these seniors must now bring out their voices to show us how best to maneuver and to get the terrain of blood pressure control under very, very good control. We go with the rest of the world. I think 120/80 millimeters of mercury should be taken to be the ideal blood pressure. And so, while as we will agree with the targets that have been set by the European Society for Cardiology of less than 130/80 as being control, we will still be conservative. We will still maintain our 140/90 as our targeted blood pressure. And ladies and gentlemen, I think we need to work towards that. And to do that, we need to get to use drugs that are effective, drugs that have least side effects, drugs that are affordable, and drugs that are going to be available. And so, talking from that angle, we will be advocating with the Ministry of Health to try and bring into the government sector drugs that are going to be, to reach this criteria. But at the same time, to companies like Cadila is to say, can we have these drugs brought into an affordable range for the majority of our population? Prices must come down, and we must make sure that we have combinations which reduce on morbidity that comes out of the side effects of these drugs. Next slide, please. And so, talking about blood pressure control targets, yes, I think this slide just shows us how we ought to be proceeding in control of blood pressure. And the Zambian Society for Hypertension still insists on using the 3-grade system because it gives us an opportunity for quick judgment when it comes to therapies. I think in our treatment guidelines, we've said, yes, we'll make guidelines that are simple to use. And so we've said, for those who have grade 1 hypertension, you may actually get away with 1 drug. For those who have grade 2, you may actually achieve optimal control with 2 drugs. Those in grade 3, we need to go for 3 drugs. We try and go for multiple drugs, but low dosage. That way, we get better control of these blood pressure readings. Next. But also to say that, for those who have comorbidities, we need to aim for lower thresholds of blood pressure. So diabetics, we need to insist on 130/80 as being the targeted blood pressure. Those who have had myocardial infarction or are having symptoms of angina, especially if we can prove that, they have hypertensive heart disease, meaning that they have myocardial hypertrophy, we need to insist on lower blood pressures in those patients. Meaning that we just need to have more medication on board to try and reduce on disease and death. So you can see how the terrain of our non-communicable diseases has changed over many years. In 2009, we had one list of drugs, of diseases. And you can see that the highest in that rank was stroke at number 5 or at number 6. And we had ischemic heart disease at number 8, and hypertensive heart disease was on number 15. Okay, now there are many reasons why it was that low at that point. And so I won't get into that. Just to say that 2019, this whole list has changed. We have stroke now at number 3. And we know that the major cause of that is cardiovascular issues, hypertension being the most prominent among the causes. And then our ischemic heart disease has come up to number 7 now, and hypertensive heart disease is at number 10. So we have more and more hypertension-related morbidity and hypertension-related mortality coming up. And I think this trend is going to continue until we do what it takes to bring it all down. Next. All right, so it's just to say that, as we attend to hypertension as a disease, we always ought to have in mind the risk factors to hypertension, of course. And so in treating high blood pressure, let us also think of treating risk factors or treating cofactors, I should say, meaning that it's time we considered looking at cholesterol. There's a way in which we need to look at arrhythmias as well in these hypertensive patients, because those are what lead to hypercoagulable states. And so we ought to look at cofactors to hypertension and the risk factors to hypertension to make sure that we treat not only the blood pressure itself, but treat all its relatives as well. And I wouldn't think my talk is complete if I didn't mention tobacco, which you can see among the risk factors to rise if nothing is done. We ought to work towards eliminating tobacco, and I really think it's one of those nuisances that we can actually do away with. Next slide, please. Yeah, so I think in my talk, I've already talked about these issues that surround blood pressure, and to just say how important it is. And so we'll skip this, we'll go to the next. Yes, Abhijit, could we have the next slide, please? Okay, and this, I think, is what makes hypertension also to be a rather complicated disease to attend to. In that what we measure in the clinic when a patient comes to us is not the only truth, so to say. Yes, we would want to have people come into the clinic and we have their blood pressures measured, and then we should be able to say, yes, this is hypertension, let's treat it. But we know that there are other factors around the patients that have made us not make that diagnosis or delay in making that diagnosis. And so I think as we go forward, we need to be more aggressive, and we need to define hypertension nicely, so that even with one attendance at a clinic, we should be able to start someone on antihypertensives, rather than, as we are saying now, that people must have 2 raised blood pressures on 2 different days. And I think those are just delaying tactics. We don't need to go that way. We ought to make a diagnosis on a single visit to our clinic, but at the same time, we ought to rely on other diagnostic tools to diagnose, especially masked hypertension. This is just the opposite of white coat hypertension. White coat, I think we all know what white coat is about. We thought it was harmless in the beginning, saying, no, in the clinic is high, when they're at home it's down, and therefore it's okay. But I think now we know that white coat hypertension is just a precursor of actually chronic hypertension. And so if we don't attend to it early, we will soon realize that actually we already have cardiovascular complications that have been coming out of the injury that has been caused by high blood pressure. And then we have masked hypertension, of course, where blood pressure is normal when they come to see you. When they go home, the blood pressure is up. Meaning that we have to advocate for the use of other diagnostic tools. We have to have more use of our ECG machines and more use of our echocardiographic machines. And I really think that our friends have gone forward now to try and capacitate more ultrasonographers to do our echocardiography, so that we can use what we have at hand to diagnose hypertension and its complications and see how well to go forward. But ladies and gentlemen, as we attend to all these issues around hypertension, we need always to have in mind that we are in a world that has a lot of information that we need to be relying on when we give these therapies to our people. And this evening, I think we will take time just to talk about angiotensin receptor blockers. How well do we utilize them? And angiotensin receptor blockers have multiple benefits in not only bringing blood pressure down, but also in controlling the complications that come out of hypertension. Next slide, Abhijit, if it's not my last slide. Okay, we go next. And we go next. Okay, this is a good one, okay? In that I think it shows us now what actually hypertension does. And this is the basis of our gathering here tonight. We need to delay these complications. If not, we need to eliminate them. As I said, just as we've eliminated the complications of HIV, we can do it in hypertension as well. Let hypertensives live normal lives, meaning that we don't get to the stage where they have where they have hypertensive nephropathies. We don't have to get to a stage where there is really morbid left ventricular hypertrophy. We don't need to have people getting retinopathies, okay? Actually, I had a friend who is blind now in both eyes because of hypertension, and it's very, very traumatic. There is a way in which we can actually control that, and that is by use of therapies. And I hope angiotensin receptor blockers are among those which can actually attend to more of these than one. We need to obviously try and get to a stage where we use less medicines really to control one disease. Okay, someone has said that hypertension is one disease. Why don't we use one tablet? And they are correct. But as it is now, the pathophysiology is so complex that we actually have to use multiple drugs. But where does angiotensin receptor blockers come in? And so I think we will go on to listen to Dr. Beshara from there. And then we will get back to discussing more science in the question and answer session that is going to follow. Thank you very much, ladies and gentlemen. And I think I'll ask Dr. Beshara to get on with the story on angiotensin receptor blockers. Thank you.
Thank you, Professor Goma. When Professor Goma talked about hypertensive, he nourishing in Zambia Hypertensive Association as his own kids. We really thanks Professor Goma. We wish you all the very best. And at the same time, I would like to request call upon Dr. Bishara, specialist physician of Coptic Church Hospital. Dr. Bishara is the specialist in Health Professional Council of Zambia, specialist in Egypt Medical Syndicate, medical expertise in the Egyptian Ministry of Health Science University Teaching Hospital, Coptic Church Clinic, and Mind Care Center. So welcome Dr. Bishara for his talk on today's the very auspicious occasion, that is live webinar on World Heart Day. The slogan of this year of World Heart Day, connect heart with heart. So welcome Dr. Bishara.
Good evening, Abhijit. Thank you very much for the introduction. Just trying to get the slides in order. Yes, this one. Wait.
By the time Dr. Bisar is starting, let me tell you that Cadila Pharmaceuticals is here in Zambia since 30 years, and we are trying always give you the quality product to your patient to serve you better way. And we have entire cardiac range that can be served to your patient. We have other segment as well. We are very strong in gynae segment, ortho segment, cardiovascular, as I told you, even in respiratory tract infections. So we here always believe to give a quality medicine to your customers and serve your customers and clients in better way. We have a very iconic product that is for world famous product, that is Rabeloc IV. Cadila Pharmaceutical first time has introduced in 2004 the Rabeloc IV, first injectable PPI, which is registered almost 65 countries, and that has been given a very wonderful result, clinical results. Even individuals support the Rabeloc IV the way it's got. It's a really wonderful PPIs available in African market. And this is an international brand, so your patient can get any corner of the globe.
To sort out the slides is always slides which disappear at the last minute. But
my apologies for participant, maybe there is some technical glitch. So again, Dr. Professor Goma, over to you.
Yeah, thank you very much. So it's just to say that, you know, as we look forward to wave 4 of COVID-19, we ought to find ways in which we are going to get the cardiologists more involved in care of these patients. And not only that, but I think it's also to try and get the doctors to attend to these patients as patients. I think in wave 3, we are attending to these patients with a lot of fear. Immediately you realize someone has COVID, you think that they are not hypertensive, they are not diabetic, they are not asthmatic, and they are just COVID. And so you want to send them to Levy, and we expected Levy to do wonders. But I really think that, you know, for now, can we all be resolved that, you know, we will make sure that before we transfer these patients to the to the COVID care center, we have taken care of their comorbidities, especially hypertension. We need to find a way in which we will put them on correct therapeutic regime to bring the blood pressure down, so that when they get to the COVID center, our COVID friends just have COVID to attend to, because we have attended to what else is on them. And so I'm hoping that we will double our efforts in learning how best to look after hypertension, to make sure that the best is done going forward. So we will be hoping that we will officially launch the, treatment guidelines, and that we are going to get consensus around their use, and that we will get a buy-in from our medical stores limited, so that the medical stores people can actually order the set of drugs that we think are optimal for management of hypertension in Zambia. That, of course, is going to bring down the prices. Right now, I think we all use our own choices, and as such, some of the drugs have very little demand, and our business colleagues keep their prices up. But I really think that, you know, with pooled resources, we should be able to get more of certain medicines, and by bulk stocking, we should be able to have their prices coming down. So I'm hoping that Cadila is among those companies which are hearing our cry for cheaper and better drugs. And we hope that they are going to not only decide to be the leaders in reducing their prices, but they are also going to tell their relatives to do the same. I think we are ready with the talk from Dr. Beshara. And we are hoping that you are all tuned in and waiting for us to discuss through this whole topic tonight.
Yes, I can talk. I have no problem. I have no problem.
So are we ready to go on the other side? Okay. Yeah, so for our friends who are out there, just to say that, you know, there are a number of us in this room where we are launching this evening. And so you are welcome to ask as many questions as you would want. And I'm sure one of us will have an answer for you. Looking around the room, we have Dr. Chimanuka, our dearly beloved friend. We have Dr. Kalinchenko hiding in the private sector, but it's good to see that she's still around. She's here tonight. And we have Dr. Lorita Kabwe, our main interventional cardiologist. We are very, very proud of her. And I was being told that she's so busy that she cannot attend meetings such as this one. But I'm happy that she's here tonight with her signature smile. And so we can have some questions on interventional cardiology. We are covered. We have Dr. Macha, of course, our dear beloved friend from Obs and Gynae, but this man loves physiology, and that's why I love him as well. He's here tonight, and I'm sure we should be able to talk women and hypertension and issues such as that. Now, having said that, I think that's the next topic that Dr. Kawe must address, because in our registry so far, we are having an excess of women. I'm not sure why, okay? Heart failure patients, 60% are women, 40% are men. Now the question is why? But someone has said that women are special, but they should not be special when it comes to heart failure, okay? And yeah, Dr. Kamanga is here, okay? Our endocrinologist. And so please feel very free to ask us any questions. And then we have Dr. Mulenga, our dearly beloved physician from Lusaka Trust. And then we have our colleagues, Dr. Radwan. Dr. Radwan is here, and Dr. Barakat. Okay? So we have a very good collection of people to answer questions at the end of this thing. And please feel free to join us. And I hope you can feel part of the audience. All right. Okay. So Dr. Beshara says that we will have question and answer now as they load his slides on the other side. So are we able to get any questions in, Abjit?
Yes, thank you, Professor Dr. Goma. Let me hand over this session to our medical director, Dr. Bipin Seth from HO. Dr. Bipin Seth, I would like to introduce you in this platform. Please introduce yourself to the group, and then please take through from here. Thank you, Dr. Bipin. Thank you, Professor Dr. Goma.
Thank you, Abhijit. And hello, Dr. Goma and Dr. Bishara and the entire team there. Hello, how are you, sir?
We are very well, thanks. And it's good to see you, Dr. Bipin.
Yeah,
we hope you come to Zambia soon.
Good to see you. It's like, you know, namaste from India. So hello to everybody, and a very good morning, good evening to because since a lot of people are joining from different locations, right? So namaste or hello everybody. This is Dr. Bishara, Dr. Goma. Dr. Bishara still seems a little lost. Dr. Bishara, everything is okay?
No, some technology
Yes.
has gone wrong, so
Okay,
he's still loading his slides.
Nothing
Oh, there
is
he is.
wrong. Nothing is wrong, Dr. Goma. I think everything is fine. Now COVID is going to go to heaven or hell, right? That's what we have done it. Yeah, you all have done it like this. All right. Yeah. So thank you very much. This is Dr. Vipin Seri from India, emergency critical care specialist and your host and your friend for tonight. Right, Dr. Goma? Is that right?
That's correct.
That's correct.
Welcome, Dr. Vipin.
Thank you so much. Thank you so much. Dr. Goma, we have a lot of questions, a lot of such questions. So, but first, before I go to the questions from audience, I would like to have, one pointers from my side while going through your presentation, which was a wonderful presentation from your side, right? So, can I have this slide,
Vipin,
please? Or are we going to go to this slide deck? Dr. Bashar, are we going through this slide deck before, or we can have this slide deck off? We are taking question and answer. Dr. Bashar, can you hear me?
Okay.
Sir,
You can go ahead from here. Okay, I can go from here. Okay, so I think we are well set now. Good evening, everybody. And
All right, we
Goma,
are set
start
to
the
our thanks.
presentation. The slides are ready now. And Dr. Vipin, thank you for your intervention.
wonderful. So, Dr. Bashara, welcome back. Welcome back. And just go
Thank
through
you.
your slide deck and then we'll have, a discussion on this. Please continue the slide deck. Thank you.
Thank you very much. Good evening, everybody. And sorry about this technical delay, but we are already online now. So thank you, everybody, for coming today. And thank you, Professor Goma, for the introduction. And I would like to make it brief and clear that we would like to talk about the role of ARBs in the management of cardiovascular disease. I will go through the slides a bit fast because I'm talking to specialists, so I don't need to emphasize too much on that. First of all, we talk about like general introduction. We all know about the renin-angiotensin-aldosterone system, and here is how the system is working, starting by angiotensin and angiotensin from the liver, worked out by renin to give the angiotensin 1, then being activated by angiotensin converting enzyme, our famous friend here, to become angiotensin 2. This is the active form, and that's going into two receptors, receptor 1 and 2. We'll talk more about it. This slide is telling us that we are dealing with, again, this is the type 1 receptors. That's what is creating the problem for us in high blood pressure. First of all, it works on the kidney, causing sodium and water retention, increasing the blood volume, and this is leading to high blood pressure. Of course, it works on the adrenal gland, causing increased aldosterone excretion. Then number 3, it works on the heart, causing hypertrophy, leading to left ventricular hypertrophy, and it works on the peripheral vessels, causing the constriction, increasing the blood pressure again, and also working the brain, increasing the heart rate. All these factors are leading to hypertension. There is a bit of good news when we talk about receptor type 2. Okay, it can help us in 2 ways. On the heart, it has like anti-proliferative action, and on the vessels, it's having the same, leading to vasodilatation and reduction of the blood pressure. This slide is just like summarizing what we have been talking about now, just putting the physiology in one collection in front of us. Going to see how is the action of both groups, ACE inhibitors and ARBs. You can see here the usual pathway with the ACE converting angiotensin converting enzyme in between. Okay. Now, if we use angiotensin converting enzyme inhibitor, it will break the circle from the top there. Okay. But in the meantime, if you look at the left side of the slide, you can see that it's also leading to accumulation of bradykinin, causing angiolytic edema, and that is what's causing the famous cough of the ACE inhibitors. And that can be one of the good reasons for the patient to discontinue the ACE inhibitors. But if you continue a little bit, we'll find that if you come to our ARBs, they work specifically on the angiotensin type 1 receptors. Okay, so it can tackle the effects that's leading to the blood pressure. Another demonstration here about the same thing, that you can see how is the physiology going on about this system, but you can see that there is also some other non ACE block pathway that means that even if you are using ACE inhibitor, still there is some activation will happen through another channel, still causing the blood pressure to go up. Another slide concerning the action of the ACE inhibitors. If we start here, you can see angiotensin 1 is converted into angiotensin 2. ACE inhibitors are blocking this, but again, if you look at the right side of the slide, you can see that it's increasing the bradykinin growth, and eventually this is, as we said, one of the most famous causes to discontinue ACE inhibitors. Coming to this part here about the ARBs, if you can look at the lower part there, if it stops the angiotensin type 1 receptors, that means that it's decreasing the vasoconstriction and decreasing the secretion of aldosterone, decreasing the stimulation of sympathetic nervous system, and decrease cell growth. One quick slide is about the role of angiotensin 2 in atherosclerosis. You can see it can cause vasoconstriction and increase the angiogenesis. So all these factors are leading to atherosclerosis. This slide of complications of hypertension has been discussed by Dr. Goma already, so we can skip it. Part 2 is we talk specifically about the angiotensin 2 receptors. I will concentrate on the ones that is well known, and that's what we have available in Zambia. The first one was losartan, of course, then we have candesartan, irbesartan, olmesartan, telmisartan, and valsartan. These are the available ones and the most famous ones. In general, ARBs have shown, and that's scientific talk anyway, excellent efficacy, and they have no negative metabolic effects. They cause no accumulation of bradykinin, so they don't cause the side effect of dry cough, and they also have an ability to activate the angiotensin receptor 2, and this causes the vasodilatation, and that leads us to the most important part of our talk today. That leads to additional cardiac and renal protection. This slide is telling us about its comparison of the different families of the antihypertensive medication, and you can see that ARBs are entertaining the most persistence or consist of the use by the patients due to the much less side effects. They are followed by the ACE inhibitors, then calcium channel blockers, then beta blockers, and the least inconsistent with the patients are diuretics. I'm sure we all know why, because of the inconvenience caused to the patients. Again, this slide is giving us the same idea. If you can see, start from down, you find that the ARBs are the most consistent, then ACE inhibitors, calcium channel blockers, beta blockers, and diuretics. Here is like a bit of pharmaceutical differences between the different ARBs, and you can see that something like telmisartan is entertaining the longest half-life in the serum. Again here, that's an important point. All of them, with no exception, are used for hypertension. But what we would like to talk about it now is the protection, the cardiovascular risk disease, where to use the ARBs. We'll come to something more clear a bit later. The pharmacology, especially for telmisartan. Again, here is proving that the telmisartan has the longest half-life. If we talk generally, and that will help us in the next talk concerning the protection, the cardiovascular protection, rather than treatment only, we can see here that there is some kind of preference when we are dealing with different comorbidities in addition of the hypertension. We'll come to something easier. There's a lot of like talk here. This slide is easy and clear, and I put mainly the most famous and most effective, the ARBs. You can see that still losartan and telmisartan are like the highest in efficacy. DOC means drug of choice, and PP means potential benefit. If you can go through that, actually, it will tell you exactly when we choose and which ARB is like preferred for such condition. And that will help us on our next part of the talk. You can see here, like on the, if you can see the colon on the left-hand side, talking about cardiovascular protection. Telmisartan is the drug of choice coming for heart failure. The other drugs can help him, the other ARBs, I mean. In myocardial infarction, valsartan, and we can continue like that. Like in diabetes, still telmisartan is the most preferable one. Even in metabolic syndrome, that's how we can, from now onward, we start like differentiate between our use. We cannot consider all of them as just like one family that we can substitute easily. We need to find a good reason to choose which ARB we are using for our patients specifically. So now we come to one part that I consider it's like a dream now. And as long as we're talking about like the Heart Society, Hypertension Society in Zambia, we need to think clearly about that. We need to move with our medication from the therapeutic rule to protective rule. The target of the protective rule, of course, number one is the therapeutic rule, as usual, to improve the symptoms and signs for the disease we're dealing with, namely here hypertension. But we need to move a bit forward. We need to prevent further complications or deterioration of the condition of the patient. We need to protect him from getting more illness. Number two, we need to reduce the hospital admission, which is completely a burden from the personal and financial point of view, especially on the society. If we reduce the hospital admission, we'll gain a lot and our patient will be really helped. And eventually, of course, we better find a way also to reduce the cardiovascular related mortality. This is what we are looking for now in our talk. So we need to be clear because we are not doing this move on our own. Actually, it's like an international scientific trend now that the primary goal of today's therapeutic strategy is trying to control and decrease the existing risk factors and to consequently decrease the occurrence of the complications and consequently reduce the morbidity and mortality due to the cardiovascular related conditions here. And ARBs so far have shown the ability to reduce the complications like stroke and heart failure, which are the most common for the hypertension, as well as of all the major cardiovascular effects. You can just name it, myocardial infarction, all the other complications. ARBs have proved to have a protective role here. So now we used to say, and most of our patients, they know ARBs are strictly used for high blood pressure. We need to change this understanding now. We need to talk about ACE inhibitors or ARBs should be preferred in patients with, like, as an example, comorbidity of like microalbuminuria or renal dysfunction or even chronic kidney disease. When we are dealing with metabolic syndrome, of course, including diabetes mellitus, when we talk about dealing with patients with atherosclerosis, chronic stable angina, or even previous myocardial infarction, atrial fibrillation is a very important indication that we can add the ARBs here, and of course, the heart failure. All these rules are very important. Let us go through the different possibilities of, or the different fields that we can use the ARBs as protective measures, not only therapeutic measures. If we start with cardiovascular protection, we can find that telmisartan is the only ARB that indicated in the reducing the morbidity, and especially for manifest atherothrombotic occasions here. And that's proved all by studies. There have been a lot of studies mentioned here. I may be excused for mentioning the names as such. Okay, and it has shown a similar reduction of the cardiovascular death and myocardial infarction and stroke or hospitalization. If we move again to heart failure, we find, as we said, that the other, again, ARBs have like a very beneficial role in preventing and improving the condition heart failure, accompanied, of course, with high blood pressure or hypertensive heart disease complication. Again, when we talk about myocardial infarction, valsartan has a role in the treatment here, but even telmisartan was associated with good reduction of the number of myocardial infarctions. Can I remove this? So, as we said about myocardial infarction, you see the use of telmisartan was associated with significant reduction in the number of myocardial infarctions in hypertensive patients during the studies that has been done. Again, in stroke, still ARBs like losartan are indicated to reduce the risk of stroke. Atrial fibrillation, telmisartan has significantly reduced the recurrence of atrial fibrillation, while the other ARBs have been associated with reduced incidence of new onset of atrial fibrillation. And you know that's quite an important role for us. When you're dealing with high diabetes patient, especially when it's combined with hypertension, you find that ARBs have shown to entertain cardioprotective properties in patients with type 2 diabetes mellitus. They are also associated with lower risk of admission to the hospital for the other complications that come on top, specifically acute myocardial infarction, strokes, and heart failure. Again, in renal protection, ARBs have been very effective to reduce the possibility of reaching the end-stage renal disease, which is a very important factor in our work. So as a conclusion, with the aim to prevent cardiovascular, not only to treat, but to prevent cardiovascular events, primarily telmisartan and eventually losartan are the ARBs of choice in patients with high cardiovascular risk and a general need for cardiovascular risk reduction. In case of heart failure, the other ARB, cansartan, valsartan, sting can be help, and valsartan is still considered in treatment of recent myocardial infarction, and for hypertensive patients at risk of stroke or losartan should be the first option here, while telmisartan has also shown some risk reduction in this subpopulation. In cases of patients with history of atrial fibrillation, use of telmisartan was highly recommended, and concerning cardiovascular protection in patients with diabetes, both telmisartan and valsartan have shown much less lower risk of admission to the hospital. And eventually telmisartan may even be more beneficial in reducing the proteinuria more than the other ARBs. All these factors are telling us now that we need to broaden our spectrum, broaden our thinking concerning the use of ARBs, not only for the simple therapeutic purposes, but now to protect our patients in consideration of their different comorbidities. Now we have a lot of trials here. I think I will skip it for the sake of time. And maybe I can reach here. There is a bit of like comparison between the different ARBs. We can move again through that to come to the conclusion. Telmisartan has like a superior control of blood pressure and faster blood pressure control and safe for renal impaired patients and suitable for diabetics. And it has renal protective measures and it high patient compliance compared to CAC inhibitors. And again, it's a unique ARB, especially for if you consider the metabolic effects, and diabetes can improve the insulin sensitivity and increase adiponectin activity and reduce the inflammatory markers. And you can see that it has proved really to be very effective in treating the diabetic nephropathy. So to conclude, hypertension, of course, is a major risk factor, and powerful and well-tolerated antihypertensive group, that's ARBs, and ARBs are the best tolerance to reduce the blood pressure goal achievement, and ARBs are the best tolerated antihypertensive class, and we have seen from the beginning the slides have shown that the patient can adhere to it even over 4 years, still it gives you like 70% adherence, and there are significant difference between the different ARBs, so we need to be a bit more selective in choosing which one we go to. And telmisartan provides more powerful blood pressure control, and it's easily combined with other factors like diuretics or calcium channel blockers to give much more control in case we go to treat the hypertensive patient stage 2 or 3. And we can conclude our talk to give a space for more and more questions from your side. And thank you very much for your kind attention.
Thank you, Dr. Bishara. Thanks for nice talk. We really thank you for your time. Yes, there was some technical glitch in between. That at the same time, thank you very much for your talk. Now I'd like to request Professor Dr. Goma, please take the session through or further with Dr. Bipin Seth.
Thank you very much. I think Dr. Vipin had already started on this segment, and so could I ask him to please go ahead and lead the question and answer session? Dr. Vipin.
Yes, thank you very much, Dr. Goma, and thank you, Dr. Bishara, for the wonderful talk on ARBs and the role of ARBs. While taking this session forward, Dr. Goma, my first question and discussion point is with you. While in your discussion and your presentation, there was one very important slide which says, the ischemic heart disease, while we compare from 2009 to 2019 and 20, while it was ranked number 8 in 2009, which has gone up to number 7, the hypertension, while rating, the mortality and morbidity, which was number 515 in 2009, and it has come up to number 10. The stroke ratio from 6 to number 3. If I look at the overall, the incidence, it is for hypertension is almost 60% of population. The stroke is about 58%, and the ISD is almost about 20%. So what are your opinion? What are your views on this? Generally we see a trend in any country, it has to go down. We are working towards that, and the ISD, the hypertension, the stroke population has to, trend should be, the downwards. However, what we see the trend here in Zambia, which is going a little upward. What's wrong somewhere? What is your opinion, Dr. Goma, on this?
Thank you very much, Dr. Vipin. I think, when it comes to ischemic heart disease, I will ask Dr. Lorita Kawe to give us an opinion here. When I started practicing a few years ago, it was very, very rare to find ischemic heart disease in Zambia. Okay, and even the time I think they were talking of bringing a cath lab to Zambia, several of us were skeptical. But now I think it's a necessary tool that we need. And I think, if we had all that it takes to keep our cath lab open at UTH, we would be diagnosing more ischemic heart, more coronary artery disease in Zambians per week. Dr. Kawe, what would be your opinion? Probably you would need to come this side and shout. Yeah. Yes. You have a very small voice. Yeah, thanks.
It's very important for us to know this. It's very, very important. Yes, Doc, your opinion, please.
Good evening. Thank you very much. Thank you, Prof, for that question. So ischemic heart disease is actually quite common in Zambia previously because it wasn't really looked for by our doctors, but it's quite common. In terms of how we see it manifest, most people don't know how to recognize it. Patients usually come with complications. So you find that most of the heart failures that we diagnose are actually ischemic in origin. And then in terms of stable coronary artery disease, it's also quite common. So it's just a question of diagnosis that obviously our doctors need to be taught how to diagnose it and how to identify it. And yeah, so the thing is, in Zambia, most of the focus has been on infectious disease thus far. There was a lot of HIV, attention to HIV, TB, and malaria, and less awareness to ischemic, to non-communicable diseases. But now that there's more voices now, there's now more awareness in terms of prevalence of this condition that wasn't really looked at before. And now that we're able to practice advanced form of cardiology, advanced forms of therapy, we are now making them more aware that this condition needs to be looked for and identified and treated appropriately. So it's just a question of diagnostics, as well as the doctors being made aware of how to treat the condition, how to look for it, and so on. Yeah, so most of the time that we get patients with heart failure, they're usually undifferentiated. So what we are trying to teach our doctors now is it's not enough just to say the patient has heart failure. You have to look for the cause. And one of the diagnostic workups for heart failure, especially for patients that are above 45, is to do an angiogram. And you find that most of the patients that we've endeavored to do that, some patients, not most, are going to have coronary disease, and this is obstructive and it needs treatment. So it's just a question of looking for it and knowing how to identify it.
Exactly. Thank you very much, Dr. Kabwe. So there's a lot more happening down here, Dr. Bipin. Okay. But we are thankful that at least we have some diagnostic tools now to get it done. But the issue of, metabolic syndrome among Zambians, I think is getting more common. And to some extent, also the issue of antiretroviral drugs bringing about, these epidemias. Also that contributes. And in hypertension, the issue of left ventricular hypertrophy. I think we are having a lot of hypertensive heart disease now, and that, predisposes the myocardium to infarction. And all that, I think, taken together makes us, up our game when it comes to diagnostics. And so Dr. Kabwe was right on the spot. We need to do better when it comes to diagnosing. It's not enough just to know what the blood pressure is, but we need to actually know what else is causing, so that when you give your therapies, you actually attend to many more things. And that's why it was good to see Dr. Beshara's presentation. I think he made us look into many more things that would come because of cardiovascular disease.
Dr. Oma, you hit the right nail. What I feel is, since I've visited so many times to Zambia, Lusaka, and the Copper Belt, and many other places and all. I feel, like today in the world, when a lot of places, it's like intervention. We've been talking about cath labs, angiography, angioplasty, whether it's SVD, DVD, or TVDs and stuff like that. While I'm not sure how many cath labs we have, and even if we have a cath lab, what I remember, about 3-4 years ago, there was only one cath lab, that too in Lusaka. And all, if you go to the interiors and all that, there's not even a cath lab. And even if there's a cath lab, there's nobody, interventional cardiologists, there's not much. I mean, other than you guys there. So I somewhere feel, how to manage this condition. How about thrombolizing? How about, educating the people, educating the doctors, the medical fraternity who are really not an interventionist, but then, looking at the ECG and immediately thrombolizing and all. So there are a couple of products, we can use on this. What do you think, how do we go about this? So I understand, as you rightly said, diagnosing. This is the first important thing, is diagnosing with CVST elevation, the ECG and stuff like that. The second most important thing is, how to immediately counter that, the treatment part of it. That may be, some medical management or intervention. So what exactly as a SOPs or as a flow or as a, the system we do in Zambia? Would you like to throw some light on this, Dr. Goma?
Yeah, well, I mean, in terms of diagnostics, I think now we have 3 cath labs in Lusaka, isn't it? 4. We have 4 cath labs in Lusaka. And Dr. Lorita Kabwe is our own Zambian interventional cardiologist, but we also have a few colleagues who have come in. Who else? Dr. Radwan. Yeah, he's also an interventional cardiologist. And who else? Dr. Amit. Okay. And Dr. Haitham is also interventional. Okay, yeah, so there we are. So we have a few more, but really talking about thrombolytics, they are an emergency. We need to get them into Zambia, and then we need to start training for the use of thrombolytics. Because it's something that, was not an emergency in the past. We would argue about infarction, myocardial infarction before, but now I think if the ECG shows that it's infarction, most probably it is infarction. So before we go to doing stents, we are hoping that our friends in the cath will be on hand also to put in stents. But really, we need to thrombolize. And right now, we are all not trained at thrombolytics. And so Dr. Kabwe and her friends have a lot of work to do. But it's really an emergency. But while we are talking of thrombolytics, I think we also need to be talking of these drugs which try and reduce myocardial wake, so that we don't get that very huge infarcts. And so we hope we can have good use of beta blockers and we can actually fully utilize aspirin and other anticoagulants, so to say, to try and bring down.
How about using, thrombolysis?
Maybe I can add in.
Let Dr. Dorita Kawe come in. Yes.
I'm really sorry to intervene, sir, but if you keep two devices close to each other, it would create a disturbance. So I request either like panelists can join in on single screen one by one, or you can keep a device farther away from, so that it can incubate all four panelists in one screen.
Yes. We must socially distance.
Yeah, thank you very much for intervening, support team. And the Koma, coming back to you,
Dr. Kawe wanted to say something.
So someone has to mute their mic as well as speaker, please.
Have you muted yours?
Yeah.
Okay, thank you.
Okay.
So, Dr. Rama, coming back to you and Dr. Bishara and the team there sitting, I see a wonderful panel there. Yes, Doc, a wonderful panel there. I see there are 3 or 4 cath labs, and it's very difficult. Anybody coming from interiors and having an ISD and MI, maybe there's the golden hours. I'm sure you would know about the golden hours and stuff like that. How can we all as a team, I'm talking as a medical fraternity at a pharma company, how can we help everybody, to understand those ECG quickly? There's an ST elevation or a depression, and quickly, we need to thrombolize, and we give, all the CCBs and stuff like that. How can we help those patients? I think that's the real motive out of it. So by the time, people come, it's been 24 hours, there's maybe SVDs, DVD, TVDs and stuff like that, and we do angio and angioplasty, and not everybody can afford. Maybe we can go to different, scenario, and how we can help the entire population, not only in Zambia, because a lot of medical fraternity and people have joined from other part of Eastern African countries, and also how we can help them. I think that's the main thing, we should talk about it. So some pointers from your side, the panel sitting in Lusaka. Doc, from your side, I can see you and Dr. Goma, Dr. Bishar, and everybody who wants to say something on this. Before I go to the next question, which is from one of the audience, if you can have a little summary from your side, please.
Okay. So I just wanted to add on to what Professor Goma said in terms of how we are trying to endeavor to treat patients that come in with a STEMI. So obviously at the moment, the country only has 4 active cath labs, and all of them are located in the capital city, Lusaka. There's 2 in the state and 2 in private. So that means that we can't really offer primary PCI to all the patients. So what we are trying to develop is what is called the hub and spoke theory, or way of doing things, where doctors are taught how to identify a STEMI and thrombolize right away. Then the patients come for invasive therapy. So we have the pharmacoinvasive type of therapy. But the question is, are the doctors able to identify what a STEMI is and what are the timelines and so on? So that's where we need a lot of work to be done. We've done a few lectures, online lectures, to try and teach the doctors what to do. We'll see if those teachings have gone through. So far, we've been receiving quite a number of referrals, and of course, where they are not sure, they send the ECGs. Now there's WhatsApp, there's all these online apps that they can use. So when they're not sure, they send the ECGs, we give an opinion, and then the patients are treated. But the problem is availability of the thrombolytics. Most towns do not have access to even streptokinase. So that's a problem. The doctor might be able to diagnose the STEMI, but they don't have anywhere to find the lytic. Most of the time, it's usually just in the main towns that they can find streptokinase. But if they are in the far-flung areas, then they are not able to do it. So it's a multi-pronged problem that obviously will take a bit of time to resolve.
So I think wonderfully responded by you. And may I request, if I can request the Cadila team here, because Cadila has STPase or streptokinase, and it available. I think that two-prong approach. Very rightly said, one is to understand and know the STEMI. So that means, to read the ECGs and to know that there is a STEMI and all, which is one approach. And at the same time, once you know STEMI, the availability of drug, which is, thrombolytic agents like STPase or streptokinase and all. So, if Mr. Abhijit, Nikhil and team, the Cadila team can make it available at all the places, I think we can do a lot of good work for people of Zambia. I think we should do something like this. So I understand a lot of intervention is in Lusaka but initially this thrombolization is very, very important. While we are talking about silent killer, otherwise, what happens? It still remain a silent killer. We've been talking, we will talk, we will have this webinar, we'll have all these talks among medical fraternity and all, but patients are not going to get benefited. I think, Abhijit and Nikhil, you need to work really hard on this. Just ensure that, every medical fraternity person in the interior understand the ECGs with the help of, this a wonderful panel sitting in Zambia and Lusaka, Dr. Goma, Dr. Bishara and team, and Dr. Lara, all these people, and then made the medicines, make it available there, right? I think one we can do something like this. Otherwise, this number, which is, it was 15 in 2009, which has come up to 10. So it'll keep on growing, while our aim is to bring it down, right? As a responsible citizen on this globe, we'll have to do it. So thank you very much for all your responses and all. I think I'll move to the next question, which has come from one of the doctors from Nairobi. And the question goes like this, are there evidences to show that COVID survivors do suffer from long-term CV complications? It's a question to the panel, Dr. Goma, Dr. Bishara, and the entire panel sitting there. Anybody who would like to respond to this? I repeat the question. Are there evidences to show that COVID survivors, people who have been suffered with SARS-CoV-19 or the COVID infection, do suffer from long-term CV or cardiovascular complication? Over to you, sir. Now, Goma, it seems you are muted. I can't hear you.
Can admin unmute him?
Yes.
Can you hear us now?
Yeah, Goma, it was a little breaking. Maybe we can.
Okay.
Can you try it, please? Yeah.
I was saying we are running out of time. Could you give us a list of questions so that then the panelists here can go through them? Rather than us going one question at a time. You have more questions on your side.
So your voice is breaking, Goma. Your voice is breaking. Can you come again, please?
I was saying, can we have more questions?
You are again, and I'm sorry, there's some technical glitch and we can't hear you. Maybe your device, you rotate and try something different. Can we request support team to you intervene?
Sir, if there are
Yes. Mr. Ethan told me. Yeah. Yes.
Sir, if there's a mobile device, you can direct the question to the respective speaker and they can hand over the mobile device to the person who's taking up the question. That would be the safest thing.
Dr. Bipin, I think you are muted. Dr. Bipin.
Yeah, I'm muted. Yeah, please, Abhijit. Can you hear me now?
Sound is not coming, Dr. Bipin.
Can you hear me?
Please increase the device volume.
Vijit, can you hear me?
Yes. Sir, actually, we are running out of time. So I would like to request, as Professor Goma is requesting us, that if you have questions, put together at a time so that we can finish up and then we can conclude the session.
So we do have many questions, Abhijit, but considering time and all, maybe, I'll just quickly, ask one question, and then other questions, maybe, we'll request for email IDs and then we can respond to that. So Dr. Goma, the question goes like this quickly. Can you hear me, Dr. Goma? Abhijit, I can't hear Dr. Goma. I can hear you, but I think, and if I can't hear, I think audience won't be able to hear it. Abhijit, can you hear me?
Yes, I can hear you, sir.
So can you just, you are around Dr. Goma, and if you can just, Dr. Goma, you're not audible, please. So I'll just go to the question once I'm audible to you. Nikhil, there's something wrong, a little technical issue. I think if you can just quickly go to that. But I think for our audience, we have received wonderful response. There are many questions, but if we consider, the time gap and all that, we understand all your questions are valid. We have received all your questions, and all the questions will be shared with the panel. And if you can just share, or if we have, our technical team can definitely tell us if we have their email IDs and all, we're going to respond to you on your email. There seems to be a little technical glitch, but I'm sure you enjoyed this part of it. And most importantly, silent killer. If you look at the silent killer, what we were talking, and ARBs and all, I think today, very important, while Abhijit and Goma, they are, coming out of this technical glitch. Let me just brief you very quickly on this, and which you all know. Today, the point is not treating hypertension. I think the most important thing is the complications, and the complications that leads to real mortality. Mortality, when I say it's really, the death. That's the most important thing. And that's why we call it silent killer, because hypertension, there's a sequence, there is a series. Hypertension will lead to heart failure, and then pulmonary hypertension, then it goes back, there's a cardiomyopathy, and then right, and then the left, and then the right ventricular failures. And then ultimately what happens, heart can't cope up. It has to stop one fine day, and there is a cardiac arrest, which before cardiac arrest, it goes in ISD and MI and stuff like that. But my humble request to all of you is, there is a lot available in this globe. There's lots such medicine. There's a lot of, the data. There's a lot of knowledge which is available. So let's keep sharing that knowledge with each other, right? And I'm sure Cadila would be the one company who is open to share a lot of knowledge. They have a lot of subscription. If you want any trials, any references, and anything. And Dr. Goma has been doing wonderful work. This entire panel we've been discussing, last couple of years, we've been doing a lot of things. We wanted to come out with hypertensive guidelines. We wanted to save the patients. And I remember, the first cath lab, which was put up in Lusaka, which was by some Japanese company. And then, we were not finding any interventional cardiologists there. And then we found, and today I'm very happy to know that there are four cath labs, which is wonderful. But still, when I see in 2009, position 15, and today it's 10. Let's do something for the society. Yeah, right. And that I request, this Kerala team, local team there. You have thrombolizing agents, streptokinase, STPase and all. And when doc says, the drug is not available, I feel pain. Drug is available. Why can't we make it available to all the entire globe? Why only Zambia or Lusaka? its entire universe, we can make it available. Drug is there. We can do that. Let's serve to the nation. Let's serve to our people. I think that's the oath we should take today. Am I right, Dr. Goma, Dr. Bishara? What do you think? That's what we need to do as a medical fraternity. And that's the oath we have taken, while we were studying and while we were going through all our medical education. And that's what we wanted to do. And today we are in a position that we can help everybody. So I think with this humble request, I would like to say, let's do it. I think let's do it. I think that's the only thing. I understand time is a constraint, and we don't want you to skip your dinners and your parties and your family time and all. I will not take much of your time. Before I close this session and all that, I would simply request, I can hear you, Dr. Goma, your smile, your laugh, wonderful. I can see Dr. Bishara sitting there and all. The final words from your side, Dr. Goma, Dr. Bishara, and the team sitting there.
Thank you very much. I'll let Dr. Bishara. Dr. Bishara, your last word.
Okay, thank you. I won't take long. Thank you very much for everybody. It has been really very nice to have everybody here. And here the panel really is like, we should be proud of everyone trying to help the Zambian people to get better and better. And I'm sure we'll get better, as you said, we will do it. So we need to think more advanced now. We need to dream more and we need to achieve more. So thank you, everybody. Professor.
Yeah. Thank you very much. Apologies for that little technical glitch. We hope we'll do it better next time. But really, I mean, the underlying theme of our talk tonight is about education, the need for education. And we cannot overemphasize the need for prevention in medicine. We really don't want to keep our cardiologists busy because we have not done well, downstream. So us who are working at primary level, we need to do our job. Let's keep blood pressure down. Let us keep cardiovascular complications down. Then there will be very little for our cardiologists to be encumbered with. And so I really think that these educational sessions must continue so that we teach people to do the right thing. And also, for the senior doctors to share with the junior doctors their experiences so that we know exactly how they have done it. And that way, I think we'll make good practice as best practice. Once that becomes our part of our normal activity, then we have a lot of hope for having a population that will be in good health. So thanks a lot to Kadila for giving us this time to talk together. And we hope that we can nicely get to communicate with the colleagues who were logged in tonight. And thank you very much for logging in. I think we had a huge attendance. 403 people were actually logged in. And so we hope that shows the amount of interest in getting knowledge about these non-communicable diseases, which are now becoming a pandemic, really, in this country. So we look forward to better times ahead, and we'll be looking forward to Kadila to give us not only the support in us talking to each other, but in giving us access to the tools that we want to use. As we said for tonight, good, better drugs, cheaper drugs that are accessible by the average person, so to say, but drugs that are going to do the job in trying to keep people in good health. Today is World Heart Day, and our job is to make sure that hearts are kept in good health. And tonight, I think we've done very well to use our hearts to connect. And we have connected with a lot of issues to do with the heart. And we hope that we can work together to promote better heart health, especially as we are recovering from COVID-19. We need now to build back better, as the theme has gone all this time. So thank you very much for tonight. And I'll now hand over to Mr. Nikhil for a vote of thanks. Nikhil.
Thank you so much.
Thank you, Professor Dr. Goma. Thank you, Dr. Thank you, Dr. Beshara. Now, this session of speaker and panelists, we really show our gratitude that you people are there since long time. There, in between, there was some technical glitch. We really apologize for that. And that session is over to Mr. Nikhil. And after that, we will close this session because we have some another agenda for the day. Thank you.
Thank you so much, Mr. Abhijit. So, ladies and gentlemen, very good evening to all. I am Nikhil Vankadekar from Cadila Pharmaceutical Limited. I am country sales manager. On behalf of Cadila, it gives me an immense pleasure to deliver the vote of thanks to this event, to all dignitaries and assembled here. I would like to thank you, our speaker, for live webinar, Professor Goma and Dr. Beshara, and all panel members who are present here. I would like to thank our Cadila team from ISBU, our ISBU head Mahidwas sir, Vipin sir, Pushkar sir, and Mr. Abhijit. And last but not least, all the attendees who are attending from Zambia, Uganda, Kenya, and the Congo to making this event as a grand success. Once again, thanks to all.
Thanks everyone. This is again once again thanks. We really thanks the way you have listening our speaker, our panelist. We Cadila Pharmaceutical will always try to serve you better way. So it is the end of session. Thank you very much. Stay safe, stay healthy, stay blessed.